Welcome back to Uncovering Bailey and Love. Today, we're diving into some inflammatory breast conditions you don't see every day. We're going to be talking about tuberculosis, duct ectasia, actinomycosis, and even Mondor's disease. It's like the inflammatory conditions that really make you think twice.
Yeah, these aren't your run-of-the-mill mastitis cases.
Right, exactly.
Let's start with TB of the breast.
Okay.
Now, it's not super common in our practice, but when you have a patient who presents with a chronic breast abscess and it's just not getting better with the usual antibiotics, especially if they've got multiple sinuses and you see that kind of bluish discoloration of the skin, you really got to think about TB. Think about the potential for spread from, the regional lymph nodes,
Right.
maybe the chest wall if there's osteitis involved, or even a pleural infection.
Oh, wow.
Less likely, but still possible, is direct entry or hematogenous spread.
So when we're thinking about diagnosing this, it can't just be clinical suspicion, right? We need that confirmation.
Oh, absolutely. Histology is key. You're looking for those epithelioid granulomas with caseation, and then trying to pinpoint the organism itself. Zeal-Nielsen staining for acid-fast besi in the pus or aspirate, that's crucial. GenExpert and culture are also must-dos.
Of course.
And don't forget about the bigger picture.
Yeah.
A CT scan of the chest and abdomen can show if there are other TB foci,
Right.
the Mantoux test. Well, in areas where TB is more prevalent, it's not as helpful.
Okay.
And in terms of treatment, we're talking about a long course of anti-tubercular medication, usually 6 to 9 months.
Wow.
Patients can heal, but they may end up with those puckered scars, something to keep in mind.
Yeah, definitely. Now let's switch gears to duct ectasia, which I feel like we probably see a bit more often.
Yeah, you're right. Duct ectasia falls under the ANDI umbrella. That's aberrations of normal development and involution.
Right.
So what's happening is the major milk ducts, they dilate and fill up with debris. And this triggers periductal inflammation and fibrosis. You know what often brings patients in? It's nipple retraction. And understandably, that makes them anxious. And then there's that classic toothpaste-like discharge. It can be brown, green, even a bit muddy looking.
Right, right. The discharge is a key clue.
It is. But of course, we have to rule out malignancy and other benign conditions. Ultrasound is a great first-line tool. You'll often see dilated ducts, usually bigger than 3 millimeters.
Cool.
Management always starts with triple assessment. If there's inflammation or infection, we got to hit it with antibiotics. We often go for broad-spectrum options like coamoxiclav.
Right.
Or if we suspect anaerobes, something like cefixime with metronidazole for a couple of weeks. Now, if we're dealing with persistent discharge or a subareolar abscess, we might need to surgically excise the major ducts.
Okay, now for something truly rare, actinomycosis of the breast. I've only seen a handful of these cases in my entire career.
Yeah, it's exceptionally rare. Imagine chronic non-healing sinuses with pus, the real giveaway, black granules in that pus. But for a definite diagnosis, we need microbiology to confirm Actinomyces bacteria. The treatment: long-term penicillin injections, often with debridement of any necrotic tissue in those sinuses.
So we've covered a lot of ground here, but let's finish with Mondor's disease. That superficial thrombophlebitis of the breast or chest wall. It's interesting because we often don't find a clear cause, do we?
No, we don't. Patients will usually come in complaining of a tender cord-like structure under the skin.
Right, right.
And a really useful exam finding is that shallow groove you see when you have them raise their arm and the skin stretches.
Right.
We always have to consider inflammatory breast cancer in the differential, but luckily Mondor's is usually self-limiting. Reassurance, limiting arm movement, and just giving it time usually does the trick. It typically resolves within a few months with no long-term problems.
So even though these conditions are relatively uncommon, being familiar with how they present and how to diagnose them, so crucial for those cases that do pop up.
I agree. Keeping these less common inflammatory conditions in mind really helps us refine our approach and ensure the best possible outcomes for our patients.
Absolutely. Thank you for listening to our podcast. See you in the next episode.